Okay, hi everyone. Welcome to this episode of the REFERROLOGY series. Today we are very privileged to have Dr. Serene Wong with us, who's a respiratory physician, and we'll be talking about pulmonary tuberculosis.
Okay, so Dr. Serene, how common is TB actually in Singapore? Because we do see it in the wards, but how common is it actually in the community?
I think TB is endemic. It's endemic in Singapore. It's endemic in Southeast Asia. I was just doing a search online on the MOH website, and it looks like the incidence rate is 39 cases per 100,000 of the population in 2018. Yeah, but the absolute statistics I'm not familiar.
Question. So the next question is, when should we be suspecting pulmonary TB? So I think there are some more clear-cut cases, like someone who comes in with like hemoptysis or let's say unilateral effusion, but are there more like potent manifestations that could be useful?
So I think there are some patients in whom they can be absolutely asymptomatic, right? On screening chest x-rays, we tend to find that there are cavitary lesions, there are upper lobe infiltrates that were not previously seen. And of course, then in symptomatic patients, our local guidelines suggest that anybody with a chronic cough of more than 3 weeks should actually be screened for pulmonary TB.
And in terms of the pulmonary findings, apart from like overt infiltrate, it is just like scarring the upper that the more significant to be.
So whenever there are abnormal chest x-ray findings, we usually tend to compare them against old x-rays. And then again, it depends on how symptomatic patients are. Obviously, if it looks somewhat like scarring and then we have old x-rays that show that they were not previously there, then we should screen for tuberculosis in the correct context.
Adding on to that question, so if we're sort of like screening them for TB, very commonly we sort of are told by the nursing staff that these patients need to be isolated, like sent to an isolation room. Are there any contexts in which these patients don't need to actually be isolated?
I think the practice differs from hospital to hospital. Ideally, it would be to isolate everybody in whom we send AFB sputum. But the truth is we probably tend to triage. On one hand, ours is more to rule out and some are more to rule in. It's probably those in which we are highly suspicious of that we would definitely ask for isolation, because you don't know who they're going to be next to, right? And they may end up being next to a patient who's immune compromised, and therefore places them at a higher risk. But otherwise, they don't always necessarily need to be isolated. In the outpatient setting, we don't actually admit them. So we see them in clinic, probably in a negative pressure room. We wear an N95, we examine them, we induce sputum, and then we ask them to wear a mask and go home. But then we advise them to stay at home and to avoid everybody else, any other new people they haven't come into contact with until they return for their TCUs.
Some of these effusions that actually don't really come in with like cough and we know that oftentimes in the case of effusions they may not even be like AFB positive. So but these and I do notice some degree of variability in terms of practice, in terms of the threshold to isolate like the unilateral effusions in the context of TB. So what's your take on this?
Okay, so if you know, actually most of our patients who come in with unilateral effusions get isolated. So that's the reason. The reason for that is because 20% of patients with TB pleuritis actually have concomitant pulmonary TB.
Okay.
Right? So if you think about it that way, patients with TB pleuritis is actually within the pleura. Technically, that does not spread from person to person. But it's just because 20% of patients with TB pleuritis actually have concomitant pulmonary TB. That's also partly the reason why we then send sputum for AFB, even though there is a unilateral pleural effusion. So if the AFB comes back positive from the sputum, we assume then that the effusion and the sputum findings are one and the same.
Okay. And does the presence or absence of respiratory symptoms correlate with like the infectivity? Like let's say if it's an incidental pulmonary finding versus a patient who comes in with cough, for example.
As in whether a person with cough is more likely to be infectious than a person who does not have cough, is it?
Yeah, so i.e. like your asymptomatic chest x-ray findings who comes in with, let's say, something else and then you notice like infiltrates incidentally kind of thing that wasn't really related to the presenting complaint too.
So I think regardless whether or not they have cough, as long as we suspect TB for whatever reason, pulmonary TB for whatever reason, I mean, we would tend then to isolate them, because they could have multiple cavitary lesions. They could be AFB4+, and yet, remain asymptomatic for whatever reason. Yeah.
Okay, thank you. Okay, Jane, I think you had some questions about PTB testing. So.
Yeah. So how do people sort of decide between things like induced, like pooled or two samples, and how many AFB smears to send? Sorry, that's quite a few questions.
No problem. That's a very good question. So let me ask you then, how do we diagnose pulmonary TB? What is the gold standard for diagnosis of pulmonary TB?
Cultures.
Very good, right? So we want to look for growth. Growth tells us that the AFB is alive, right? That's why we then diagnose TB. But how long does it take for AFB cultures to return positive?
Many weeks.
It depends, right? It depends on how high the burden is. It
Yes.
averages anywhere from 2 weeks all the way up to maybe 6 to 8 weeks. So if we wanted then to diagnose PTB a bit earlier than waiting for it to grow, what else can we possibly do?
And visualize the acid fast.
Very good.
Yep, so that's your AFB.
Okay, and so that would be our AFB smear, right? Okay, and what else?
TB molecular.
Okay, which represents what?
Getting the molecular diagnosis from the sputum itself.
Okay, right. So do we ever interpret a molecular alone, or do we interpret it in the presence of something else? Okay, so the way I phrase the question, it has to be interpreted with something else, right? Yeah, okay. Okay. So your TB PCR has to always be interpreted together with a smear. Yeah, okay. So if your smear is negative, but your PCR is positive, yeah, so this is TB, right? Okay. If your smear is negative and your TB PCR is negative, this may just mean that this is an absolutely bad sample to begin with. Doesn't mean anything. So therefore, a positive or a negative TB molecular has to always be interpreted in the presence of a smear. Conversely, if your smear is positive and your TB molecular is negative on this positive smear, what does it mean?
It could be other acid-fast bacilli.
Exactly. So this could be non-tuberculous mycobacterium. Yeah, so this is why we end up doing a smear, a molecular, whilst waiting for the cultures to come back. So your next question then is, how many samples do we send? So if I send one sputum sample, what is the yield? You want to guess?
70%.
Very good, 65%, right? The yield is about 65% for your first sample. If you add a second sample, how much does your yield go up?
80%.
Sorry? It goes up to 95. It goes up to 95% with a second sample. If you add a third sample?
97?
Yes, that's right. Yeah, 97. Yeah. So that's the reason why we actually send two samples, because the third sample doesn't add any additional yield. Yeah? Okay, so the next question, the third question you had was, why do some people send it 2 days in a row? Why do some people pull the sample together? So if I were to ask you, when is the best time to do a sputum induction?
Morning, I guess.
Yes, that's right, right? So most of us think that early morning sputum samples are actually the best. So if we want two samples, then it would mean sending 2 mornings in a row, right? Yeah, so the other way to do it actually is to do one in the morning, one in the afternoon. So 2 separate sittings still, but then you pull to send it off. The only reason we do that is because, remember we said earlier that your TB molecular is interpreted in the presence of a smear, right? So we usually only send a TB molecular with 1 sample. So there's AFB smear, AFB culture times 2, and then TB PCR times 1, right? That's the way we order it. So what if your second one, your smear turns back positive? Then you have to end up doing a molecular on the second one. So by pooling your specimens together, you can actually do a TB PCR on this single specimen.
I see.
Yeah, and I mean, we did a study at NUH. Yeah, and the yield is actually shown to be non-inferior to 2 separate samples.
Okay, sorry, so you mentioned that, but if let's say I send 2 back-to-back morning samples, I send morning today and I send morning tomorrow, I'll only send 1 TB PCR as well.
That's right. That's right.
So,
but if you pull, pull them, it means that you've pulled. That's why it's called a pooled specimen, and you send it off as 1.
Okay. I see. And in terms of the timelines in terms of when the results come out, so the TB molecular normally and the smear, they come out about the same in about the same duration.
About 24 hours.
About 24
yeah,
hours.
in about 24 hours.
Okay. And besides the results, I also understand that for like the molecular, there's also some element of resistance testing that comes with it. So what should the junior doctors be aware of apart from looking at whether it's positive or negative for molecular?
So we've seen how the TB molecular results are reported, right? So the first line tells us whether or not the TB PCR is detected or not detected.
Yep.
Correct? So Jane, what's the next line below it?
The gene.
Okay.
Yeah.
What gene is that? Do you know?
I think it's for rifampicin resistance.
Yeah, very good. So it's RPOB gene mutation.
Yep.
Yeah. So if the RPOB gene mutation is detected, we think that there could be rifampicin resistance. Okay. So earlier on we talked about culture, right?
Yep.
And like all other kinds of bacteriology studies that we do, when an organism is grown, we then look at sensitivities to the organism, right? So the same thing for TB. So antibiotics are obviously tested on the TB to then see whether or not it's resistant or whether it's susceptible. So how do we define MDR-TB? Yeah.
So I think for multi-drug resistance, there has to be resistance against rifampicin. I can't remember whether isoniazid as well.
Yeah, so that's 2. Okay. So for this to be called an MDR-TB, you need to be resistant to rifampicin and isoniazid. Okay. So earlier on we said, right, it's going to take us 2 weeks. So from the time we obtain sputum, it may take us 2, 4, 6 weeks for us to get the organism, and then another further probably 1 week or 2 to get sensitivities. So if I were to empirically start the patient on RHEZ, only to find out 8 weeks later that this is a resistant organism, I would have wasted 2 months of treatment, right? So that's the reason then why a TB molecular would be important in this case, because if we detect RPOB gene mutation, it means upfront that we assume that this is MDR-TB until proven otherwise.
Okay.
So if that's the case, we go straight. We probably, after discussion, we will most likely go straight to second line treatment. So what's second line treatment?
So that would include injectables like streptomycin. You can also consider oral agents like levofloxacin.
Okay, so very good. So the cornerstone treatment for MDR-TB is a fluoroquinolone and an aminoglycoside. Yeah? So if you're resistant to this two, what is it called?
Extensive.
Very good. So it's XDR.
Yeah.
XDR-TB, right? And if you're resistant to either one, then it becomes pre-XDR-TB. Okay, so this is also partly the reason why then we become a little bit more particular when we want to give levofloxacin to patients who we think have community-acquired pneumonia, but in whom we want to look for PTB, because we think that a cause of fluoroquinolones can actually mask the pickup rate, of pulmonary tuberculosis.
Got it.
Yeah, so does that answer your question?
Yep, it definitely does. One additional question is, in patients who cannot, let's say, expectorate, and then there's concern of TB, and actually we are seeing quite a bit nowadays in this current COVID era where people don't want people to be expectorating or inducing sputum, right? What are our options in these cases?
What do you think?
I've had patients with NG tubes inserted for early morning gastric aspiration. Okay.
Why do you think early morning?
Because it pulls and builds up in the...
and then they cough it and then they aspirate.
Okay.
Yeah, so therefore 2 early morning NG aspirates. Okay, what are the alternatives? So there's sputum, there's spontaneous sputum, there's sputum induction, there is NG aspiration. What else?
I guess you can consider more invasive things.
Like?
I guess you can bronch the patient.
Yes, so bronchoalveolar lavage. Yeah, so a BAL.
Okay. The next question is about like TB Quantiferon. We tend to see this more in, like, let's say, in patients whom we are more concerned of, like, let's say, starting immunosuppression, etc. But in the respiratory context, is there any role in doing a TB Quantiferon?
Okay. Yeah. So let me ask both of you a question, okay?
Oh no.
So if I have a patient who comes in, so like assuming Jane's patient, right? So one look at the X-ray, the consultant feels like this is TB. until proven otherwise.
Yep.
Assuming two sputum samples were sent, two proper sputum induction samples were sent,
Yep.
and both of them came back negative.
Mm.
Okay, but TB is still a differential in this case,
Yep.
right? So early on we said we can either put in an NG tube, get early morning aspirates, or we can send the patient for a BAL,
Yep.
or we look for other differential diagnosis.
Yep.
So I'm going to ask you in this case, if your houseman or a medical student came to ask you, I heard that we can do Mantoux tests and we can do eGRAS, because they look for TB, right?
Yeah.
So if I did it in this setting, how would I interpret it, and can I use it to help me treat tuberculosis?
So I think it would boil down to risk factors and demographics of the patient. Let's say if it's a typical Singaporean or someone who lives in a TB endemic country, I think you won't be able to differentiate whether it's latent or whether it's active TB. That's for one. Let's say for some reason this particular patient is someone who comes from a non-endemic country, where you don't expect him to have any exposure, then maybe if let's say he's really positive, that might be more helpful. I don't know.
Okay. Jane, do you have anything to say? Okay, you just need to answer, will the TB Quantiferon be useful in that patient's case? Yes or no?
Yes.
Okay. So we do not use Mantoux or eGRAS to diagnose active tuberculosis. Okay, so in that earlier scenario that I gave you, in someone whose X-ray looks suspicious for TB, in whom the sputum is negative, we go down the NG aspirates or the BAL route. Okay, we do not do eGRA or Mantoux in that case. The only times in which we do Mantoux or eGRAS is when we are looking for latent TB.
Yep.
So what is latent TB?
So latent TB, it's the presence of TB in one's system that is not causing disease. So
very good.
Yep.
So example, if I spend 8 hours in an enclosed environment without a mask, together with a patient with pulmonary tuberculosis with AFP4+, and that person coughs in my face, and right in my face, right? So there are one of three things that can happen. So either it overwhelms my immune system and I go on to develop full-blown pulmonary tuberculosis, or my immune system mounts a response and I'm able to fight off the tuberculosis, right? Or it reaches a state in which the macrophages actually manage to wall off the tuberculosis. I'm not able to completely get rid of it, but neither is it causing me problems like you described earlier. 50 years later, if I have some kind of problem that breaks my immune system down, then this TB actually reactivates. So that's the idea behind it. So what we are actually looking for is latent TB in this case, which is the third scenario. So which is why then, say if any of us were to go to somewhere like US or somewhere like Australia, they would want us to look for latent TB, right? It's because if we go to their country where TB is not endemic, we stay there and 50 years later, right, suddenly our TB reactivates. We will actually end up spreading tuberculosis to their population. So that's the idea behind it. So we only look for latent TB if we intend to treat it. And so then that's the reason why at the beginning of your question, you asked about wanting to start patients on immunotherapy and things like that, right? So those are the only one of the few situations in which we look for latent tuberculosis, is because we know that we are going to push them into an immune compromised state, and therefore we want to look for presence of latent TB before that. But you cannot use any of these tests to diagnose active tuberculosis.
Okay, thank you.
The next question is, what baseline tests do we normally do prior to TB treatment?
So what did you do for your patient?
We checked his baseline liver function test. We also checked a HIV screen.
Okay. Was there anything else that needs to be checked? So locally we also look. Ishihara. And locally we also look to see if they have diabetes, undiagnosed diabetes mellitus. And we just do a baseline renal panel as well, just in case there's renal impairment, we need to renally adjust the dose of the medications.
Okay. Okay, so the next question would be about the first line treatment of RHEZ. I think there are, I mean, quite clear like guidance in terms of how to initiate, but I think the trouble happens sometimes when in those that have a bit of a range. So, for example, the ethambutol, which is like 15 to 20. So should we be like, does it really matter whether it's at 15, at 20 mg per kg? And I think the rest are fixed dosing, and I guess we just round up to the preparation levels lah. Yeah. So maybe for ethambutol.
So a very easy way to remember is HREZ 5, 10, 15, 20.
Okay.
Yeah, the other way is sometimes if it's a young person with a very heavy AFB burden, sometimes you go 5, 10, 20, 25. Yeah, but the order is HREZ lah.
Okay.
Yeah, and then you're absolutely right. So we round it up according to the pills.
And by burden, you mean AFB?
So yeah, like AFB 4 plus type. We
Okay.
would probably want to be a bit more aggressive. So we choose 5, 10, 20, 25.
20, 25. Versus if it's like, let's say 1 plus or not detected, then you
then maybe 5, 10, 15, 20. Because the other thing also is that with higher doses of medications, patients experience a bit more side effects. And so once they have side effects, then they become very reluctant to take medications.
Yep.
Yeah, so then 5, 10, 15, 20. And then when TBCU sees them within a week or so, then they may adjust the medications up if the patients are tolerating the medications well.
Okay, thank you. In terms of the key counseling points, do you mind like going through with us what are the essential things or things that may be commonly missed, for example? Yep.
Okay, so Jane, how did you counsel your patient?
My patient was not
counseled. Okay, sorry.
He was too sick to be counseled. But,
okay, if you were to counsel him?
Yeah. So I mean, if I were to counsel him, would tell him about the expected kind of side effects, which can start from like kind of the top, which is like, you know, orange tears or sweats, and to look out for things like if he has any nausea, vomiting, to come in to seek medical attention immediately, so that we can check his liver function tests.
Others? Any other side effects?
Other side effects, like peripheral neuropathies.
Sure.
So
what do we do to prevent or to try and mitigate peripheral neuropathy?
We give pyridoxine.
Yep, we give pyridoxine.
Yeah.
So what kind of doses of pyridoxine do we give?
I need to check that.
Okay, we give 10 milligrams usually.
Okay.
Yeah, but we give higher than 10 milligrams if they are at risk already of peripheral neuropathy. So patients like chronic ethanol ingestions, patients who are pregnant, patients who have concomitant diabetes or may have retroviral illness.
Okay.
Yeah, so in this group of patients, you may end up giving them 25 milligrams in the morning instead.
Okay.
Yeah.
Sure.
Okay. So the other common side effects, obviously, is hepatotoxicity.
Yep.
So we tell patients to watch out for jaundice. We ask them to watch out for abdominal pain. If so, then please seek treatment at your nearest GP and inform them that you started these medications.
Yep.
So if a patient comes back to you and tells you that he's complaining of abdominal pain after you've started HREZ, right?
Yep.
And then you do the LFTs, when do you stop?
If I remember correctly, it's 3 times the upper normal limit with symptoms, or 5 times the upper normal limit without symptoms.
Excellent. Yeah. So the ones that are hepatotoxic are actually pretty much isoniazid, rifampicin, and pyrazinamide. So ethambutol is not hepatotoxic. Yeah. So therefore, then it depends on how bad the derangement is. Different clinicians have different ways of stopping and retrying, re-challenging the medications. Yeah.
Okay. And for the run-of-the-mill RHEZ regimen, how long do we give the RHEZ for?
Okay. So I know that a lot of us just start treatment, right? And then we send patients to TBCU, so we don't actually know what happens after we do. So typically, HREZ is given for 2 months. The 4 drugs are given for 2 months. And at the end of 2 months, we need to trace the cultures to make sure that we are actually dealing with a sensitive strain. So once the cultures and sensitivities are out, only then do we drop to R and H. Yeah, so in other words, it is 2 HREZ, 4 RH. So there are certain circumstances in which the duration is prolonged beyond 6 months. Do you know when?
I think it's osteomyelitis, as if there's
Bone?
TB bone and TB meningitis.
Meningitis, yeah? So brain and bone, okay?
Yeah.
Or in certain patients in whom we drop the pyrazinamide.
Okay.
So if we drop the pyrazinamide, so in other words, 2 RHE, then it becomes 7 RH. Yeah, so in summary, there are only most of the time, there are 3 instances in which we prolong the duration beyond 6 months. So number 1, if we lose pyrazinamide in the original regimen. Number 2, if it's brain. Number 3, if it's bone. Okay, otherwise, even TB pleuritis is treated like pulmonary TB. It's just 6 months, at least 6 months. Yeah.
Got it. So as we talk about other regimens, I don't think we can be comprehensive in this, but maybe I think the first question is upfront. When do we suspect MDR-TB beyond, let's say, your TB molecular? Would you do so straight away in, let's say, patients who come from endemic countries that are very high risk for MDR-TB?
So under those circumstances, right, we would still do a TB PCR.
Okay.
Yeah. So it's really only if we think that the patient has got rifampicin resistance and therefore multi-drug resistant TB, do we offer other regimens? And of course, that also if patient develop allergy or hepatotoxicity or is unable to tolerate any of the original regimen.
Okay.
But once you lose rifampicin, so rifampicin and isoniazid are the cornerstone, right?
Yeah.
So the minute we lose rifampicin, actually the regimen becomes very long.
Yep.
Yeah,
Okay.
and convoluted.
So, I mean, like you mentioned, kind of, we normally start them on medications and we don't always follow them up. But in the first few days after we start the medications, we will normally check like liver function tests. Is there any advice on how frequently the liver function test should be monitored?
Okay, so I only know of this through practice. Yeah, so I know that at the 0 mark, we mainly do the baseline test that we had mentioned earlier, right?
Yep.
And then the patient is seen again at the 2-week mark. So only if the patient is at risk of hepatotoxicity, so maybe underlying chronic liver disease, chronic ethanol ingestion, or reasons, or patients complain of abdominal symptoms or of jaundice, only then do we do LFTs.
Okay.
Yeah, but every time they visit, we always check color vision, yeah, to make sure that there is no color vision disturbances. And of course, then it depends again in terms of how often we do the smears based on how heavily positive they were at the beginning. Yeah, but definitely we will always repeat a culture at the end of 2 months.
Culture at the end of 2 months. Okay. Understand. Okay, apart from the liver toxicity, are there any other complications that we need to look out for in the initial few days? And are there instances where you keep patients in for monitoring after initiation of treatment?
So firstly, in terms of the side effects, it would really largely be just rashes, yeah, anaphylaxis, nausea, vomiting, as well as liver dysfunction. Yeah. And sorry, your second question was reasons for us keeping them in, is it?
Yeah.
Okay. So sometimes it could be that the nausea and the vomiting is so bad that they're not able to tolerate orally.
Okay.
Yeah, so then that's when, if they are still inpatient, we may keep them for a while more, just to try and either adjust the dose or alter the regimen, such that they are able to tolerate this a little bit better. Of course, the other group is those in whom we are re-challenging. So we start all 4 drugs, right? And then they come with rashes.
Yep.
We don't entirely know actually which of these 4 drugs are the ones that's causing the rash, or they come with hepatotoxicity and we want to re-challenge them. So if they're already in the inpatient setting, then we'll probably just keep them for a few days more and we challenge one by one as we monitor.
Okay, the next question is about when we can get our patients out of isolation.
Sure.
Yeah. So what's the guidance?
Again, this one is very institution dependent. It's probably very I would say that if the patient is smear positive and the patient continues to remain inpatient, that maybe the patient should remain in isolation.
Okay.
But this would be a personal practice, just because I don't actually know where the patient's going to be de-isolated to.
Okay.
And he, like I said earlier, he may end up with another patient who's immune compromised next to him. But this is really just purely personal practice.
Yep.
Yeah. But otherwise, for most of the other patients we see in the outpatient setting, we actually ask them to home isolate for 14 days.
Okay.
Yeah, and thereafter, they are then allowed to leave the house, but with a surgical mask. Yeah.
I wanted to ask, right? So I mean, so we know pulmonary TB, but at the same time also there are other forms of like pulmonary manifestations like miliary TB and TB pleuritis.
Mm-hmm.
So I think you've answered the question in terms of duration of treatment. It doesn't really differ lah. But are there any clinically significant differences that we should take note of when it comes to the management of these patients in terms
Mm-hmm.
of like the likelihood of them deteriorating, other things we need to look out for?
Okay, so pulmonary TB we know.
Yep.
So pulmonary TB of the three are the only ones that have public health significance, right? And so therefore pulmonary TBs are the ones who we actually want strict isolation.
Yep.
Yeah. In terms of miliary, so what do you think miliary TB is? What do you think it represents?
Because it's like seeding. Is it like
So millet seeds, right?
Yeah.
Uh-huh. Okay. Yes, Jermaine, you were about to say something.
Is it like hematogenous kind of
Yes.
spread?
So
Yep.
it's hematogenous spread. So in fact, in patients with miliary TB, although we see millet seeds on the chest X-ray, we don't actually expect their sputum to be positive because
Okay.
it's hematogenous, right? So in fact, if I were to try and diagnose miliary TB, hematogenous spread, actually where do I get the diagnosis from?
From the blood.
Okay, actually specifically where? I mean, do we know what procedure? It's a liver biopsy.
Oh, okay.
Yeah. So in fact, interestingly, in patients with miliary TB, they don't have a lot of pulmonary symptoms, but sometimes they end up with profound shock. So the
Okay.
shock is predominant. Yeah, versus someone with pulmonary TB where the respiratory symptoms are predominant. And then TB pleuritis, we mentioned earlier, 20% of them have concomitant pulmonary TB.
Yeah.
Typically, we see it's a unilateral pleural effusion. And do we know how to diagnose it?
Diagnostic thoracocentesis.
Yes. So what do we find on pleural studies?
So it would be it's an exudative.
Very good.
Raise ADA.
Okay, raise ADA. What else?
Your TB molecular may or may not be positive.
Rarely.
Yeah.
Okay, because it's paucibacillary.
Yeah. And it's lymphocytic.
Yes, exactly.
Predominant.
So we would
Yep.
expect a lymphocytic exudative effusion with a high ADA.
Yep.
Yeah, but the gold standard for diagnosis of TB pleuritis is what?
Go biopsy.
That's right. So I still need to see growth
Yep.
of TB in the pleura. So either we do a blind pleural biopsy or we do a thoracoscopy.
Okay.
Yeah, so that we can obtain tissue.
So in the case of TB pleuritis, because quite often we make the diagnosis based on pleural fluid studies, right? And we don't have a TB molecular to go by to determine whether or not there's likelihood of resistance. So in these instances, how do you? So let's say this patient is, let's say, from a country with high risk of resistance. How do you then navigate this space?
So if say an Indian national comes with a unilateral pleural effusion, the first thing I would still do would be sputum induction.
Yep.
Sputum induction comes back negative, then obviously concurrently we would also end up doing a TAP.
Yep.
But I would probably also ensure that we have a pleural biopsy, but we would then start empirically on HREZ.
Okay.
First, yeah.
So which patients do you need to push for a pleural biopsy versus just deciding to cut the investigations at the level of the pleural fluid analysis?
Oh, okay. So most of the time we will go for a tissue biopsy unless, like we said, the sputum comes back positive.
Yeah, so the next question that we were asking is that, when a patient gets discharged from the wards and needs follow-up, you mentioned that they normally get seen like within 2 weeks. How do we decide that they are kind of suitable for TBCU follow-up or kind of a RESPI clinic or ID clinic follow-up?
Okay, so in the most important thing for all patients with tuberculosis is compliance to medications. Yeah, so DOT, directly observed therapy, is the most important thing that we should have for all our patients. For us to refer to DOT, we actually have to refer to TBCU.
Okay.
Yeah, so which is why then actually all our patients with TB are being referred. to TBCU. The only instances in which we don't sometimes refer to TBCU is if the diagnosis is still in doubt and still in question, or sometimes it's actually our own staff.
Okay.
Yeah, so then we tend to keep the patients in our clinics.
Then you
Even for, sorry? Yeah.
Then you would do the dot for them in the context of the hospital.
Actually, it's self-administered therapy, so
Okay,
it's
okay.
SAT.
Okay.
So for some of these patients who are like, say, bed-bound, it's difficult for them to ambulate.
Yep.
They would still then be seen at TBCU, but then there is this thing called outreach dot, so O dot.
Okay.
Yeah, so TBCU team then sends nurses to these patients' homes for outreach dot. So dot is the most important thing.
So what's the journey for a run-of-the-mill TB patient?
Okay, so usually we end up supplying the patients with 2 weeks worth of medications, right? When we discharge patients.
Yep.
The patient then gets an appointment at TBCU, and they bring all their own medications there, and the medication regimens gets adjusted and things like that. Patient actually immediately gets referred for dot, so they start dot the next day.
Okay.
So they go to their polyclinic, the polyclinic nearest their place, right?
Okay.
They go to a nursing counter, they present a card, they eat medicines, and then they leave. Yeah,
Okay.
and then so this happens either daily or 3 times a week. So the appointments at TBCU are regular, at regular intervals, but then the dot continues independent of, or rather concurrently with the TBCU appointments.
I see. The next question is about counseling families. So sometimes families will get very worried, like once, like they hear that a family member has TB. My understanding is that if the family has been there already, then if they have, they have. If they don't have, they don't have. So what, number one, should we be telling the family? And number two, what happens to the family in terms of like after we report this patient has TB? I think there's probably some contact tracing, and what happens to the family thereafter usually?
Yeah, so usually we just tell the family members not to worry, and that MOH will contact them for TBC, will contact them for contact tracing.
Okay.
We tell the patient not to interact with new family members who have not met them before. So we tell them Chinese New Year, no visiting. But otherwise, whoever's within your household, you can continue interacting with them because exactly as you've said, they've already been exposed. Yeah, so there's no need for separation. There's no need to avoid sharing of food and plates and cutlery and things like that.
Okay.
In terms of what actually happens to the family, yes, they do get contact traced and they do come down to TBCU.
Okay. Sorry, so for this question, as in, it's more of a practical thing because I think a lot of people will say, okay, this is reported with a RESP. And then, so first question is like, do all these patients need to be like referred per se? And if let's say they are, what should be done like before we just like refer to RESP, and what's the time interval that is, reasonable? What's your take on this?
Okay, so again, it comes back to whether these are incidental findings or whether the patient is symptomatic.
Yep.
Firstly, to address the problem of granulomas, so we would just approach these as incidental pulmonary nodules.
Okay.
So again, we would then go back to comparing this with old chest x-rays to see whether or not these are new.
Yep.
If we have x-rays from more than 2 years ago and it's otherwise quite stable and there are no new nodules that are seen, sometimes we tend to ignore them. And again, it depends on what kind of settings they are in.
Yep.
So sometimes some of these chest x-rays are done because patients are going to go to nursing homes, and so because of that, they want to make sure that they don't have tuberculosis. So if we end up seeing some x-ray findings like these, we may then ask for sputum just to look for AFB. So it depends. Yeah.
Okay. So the presence of like a granuloma doesn't really correlate well whether it's like old TB versus active TB. Like does it?
I mean, most of the time granulomas would suggest a past infection.
Yep.
Yeah, but then again, it has to be interpreted, on the chest x-ray and in the correct clinical context.
I see. So if you were to push it to a specific context of, let's say, this patient has not had a baseline x-ray before, it's the first time you're seeing this, it's incidental, there are no pulmonary symptoms, no like night sweats or anything like that, then what should we do for these specific groups? Let's say you've taken detailed history and all that.
Sure. I would then discuss this with the patient. Yeah, because this would still be an incidental pulmonary nodule after all.
Yep.
Whether or not they want a CT thorax to be done, and then thereafter sessional guidelines for pulmonary nodules.
Okay.
Yeah.
Apical scarring, does the same apply, or in terms of how we approach that?
I think the correct answer would be to screen,
Okay.
screen for TB. Yeah.
Okay. Do you have any like key take-home points about TB for like residents and junior doctors?
Okay, so you always need to have a high suspicion
Okay.
for PTB.
Yep.
Yep, we send 2 AFB smears, 2 cultures, and 1 molecular.
Yep.
There are contraindications to sputum induction, so just be careful whenever you order sputum inductions. So patients who have bronchospasm, because hypertonic saline actually induces bronchoconstriction.
Okay.
Patients who are unstable in any way, patients with active hemoptysis.
Yep.
Patients with AMIs or underlying unrevascularized coronary artery disease. Yeah, please be careful.
Okay. Thank you very much.